This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So leading off, the first speaker is Dr. John Roberts. Okay, sure that all of you know Dr. Roberts. He is the director of the Abdominal Organ Transplant Program at UCSF, our leader. And we all know that life donor transplant is really important, particularly in the area of organ shortage and long waiting time. And again, we have really one of the top life donor programs in the country under John's leadership. So John is going to talk about this controversial issue of right lobe versus left lobe life donor transplant.
Good afternoon. Good afternoon, Tony. It's always nice to see you again, say hello. And I'm always in wonder of what you're going to say next. And you say it so with such that British accent. It's just South African, I guess. I want to learn. I think it really helped me in life, but I've get a little old, I think, for people to really believe that it was real. So I just want to talk about living donor liver transplantation, and I thought I'd just sort of talk about a little bit to start with of sort of what the basics are and sort of why do we do this operation. So one of the basics is that we wouldn't do living donor liver transplantation if there were enough deceased donors available. And in kidney transplantation, that's a little bit different because the outcome of people that get a living donor kidney transplant tends to be a little bit better than people get deceased donor transplants. In living donor liver transplantation, you're actually better off to get a whole organ, primarily because when you get a living donor transplant, we're going to just give you part of a graft, and that means that the blood vessels and the bile ducts are smaller, they're harder to reconstruct, and there's really no benefit to the recipient as compared to getting living donor transplant, except cadaver donor transplants are harder to come by. So in areas such as Asia, say Korea or Japan, where there's very little cadaveric or deceased donor transplant, there's the only option that is available is for living donor transplants, and the recipient benefit from a living donor transplant is really maximal, and the donor risk would be considered acceptable. So I went to Taiwan, and they asked me to come to Taiwan and give a talk about living donor liver transplantation, and I realized that the hospital I was speaking at did more living donor liver transplantations in that last year than all the transplants, living donor liver transplants done in the United States. So I pointed that out to them right in the beginning of the talk because I wanted them not to be laughing at me the whole time. So this is sort of a map of the median MELD score at transplantation across the United States. Is this? Yeah, there it is. So here we are in California. You can see that there are these white areas, and they're areas that really don't considered to have a transplant program available. There used to be one at UC Davis, and so, but you can see that all of California is out here at MELD at 32. As you know, the MELD score over 30 means that your probability of being alive and being alive in 3 months is significantly compromised. Probably in the 30 to 50% of those people will be dead in 3 months. So it's really kind of a barrier. There are places that you can see Florida, I think Tennessee where Steve Jobs went. You know, those are places where they're light blue, and so we have people that leave California and go to other places to get transplanted. In general, we bring that up to all of our patients, that's an option to them, and as you can imagine, you have to have the right resources, the right insurance, the right social support to be able to leave California and go off and to get transplanted. But it is, you know, one of the things that drives the need for liver transplantation is really the availability of deceased donor organs. One of our previous fellows did a study with me. We looked at the MELD score at transplant. So if the DSAs are sort of the areas in the country where the organ procurement agency is called a DSA. So in Northern California, California Transplant Donor Network is the organization, and really each of those organizations has a waiting list. And so if you look at the MELD score at transplant by DSA across the country, we broke it out into quintiles. And so this is number 5 is sort of the quintile that has the highest MELD score, and you can see on this thing that if the higher your MELD score in your local area, the greater odds you are that you're going to do a lot of living donor transplants. And so places like, you know, San Francisco, Boston, Los Angeles tend to have very active living donor transplants because the MELD score at transplant is so high. So I took a look at our waitlist outcomes in Northern California because I know you guys would be interested in that. And we looked at our patients that we listed at UCSF between 2010 2012. I looked at people that have relatively low MELD scores because, you know, we think these people actually do relatively well. There were 667 patients that we listed over that 3-year period of time, and you can see that it's interesting that you have a greater chance of dying than getting transplanted. And these were people that some of these people actually left the area to get transplanted. So, and if you look at the people that got the deceased donor, there's only 130 of those. So you really have a relatively low chance of getting transplanted in Northern California compared to your risk of dying. So, you know, obviously almost half of those people ended up staying on the waiting list, but you can see that, you know, if even with a relatively low MELD score in Northern California, your risk of dying is actually fairly high. And this just shows it in sort of a graphical form. So in the people that got listed in that relatively low MELD score range, a number of them got sick enough to get a transplant, and their average MELD score deceased donor transplant was 26. So these were probably people that took higher risk organs in order to get transplanted, and that's thing I think we've talked to you about before. There are sort of older donors and say donors that have a history of potential exposure to virus that we offer the patients, if they are consent to that, for transplant. You can see it with living donor transplant, these people get transplanted at relatively low MELD, but of the people that died, you know, most of those people are probably dying of complications of their liver disease because their MELD scores tend to go up, and we just can't rescue them from transplant, with transplant. So really the benefit to the recipient for living donor transplant is well laid out by the A2ALL study, and we're a participant in that's the adult-to-adult living donor liver transplant study, and Nora Turow and Chris Fries are the co-PIs for our participation in the NIH study, and they looked at sort of compared the people that had a living donor that worked out and those people that had a living donor that didn't work out. And if you had a living donor that worked out, so they're all people that had potentially had a living donor, but they didn't work out, say, because of blood type incompatibility, your risk of death is about half of the risk of death if you don't have a living donor. So it really allows you to have a potential of getting transplanted before you get too sick. And as you guys all know from taking care of patients with liver disease, getting sick is, we like to think that, well, they'll get sicker and sicker and eventually they'll get their transplant, but we all know that getting sick is a more of a chaotic event. So people kind of go along and then they have their variceal hemorrhage, they have spontaneous bacterial peritonitis, they have some event and they sort of fall off the cliff, and some of those people sort of grab onto the branch on the way down, and then those are the people that have a MELD score of 35, and maybe we can get them transplanted before the branch breaks, but some people just hit the bottom and die. And so it's really, because of the chaotic nature of it, it's better for us to try and catch those people relatively early. In the study, it was also found that for hepatocellular carcinoma patients who had relatively low MELD scores, there is an advantage for living donor transplant, and that's because those people are, they start off on the waiting list at 22, they go to 25 at 3 months, 28, and eventually most of those people can end up getting transplanted because their MELD score goes up on a regular basis. So people with HCC actually have a great advantage for getting transplanted, and now there's a sort of a national consensus that those people actually have too much of an advantage. Now there's discussion about how to decrease that advantage, probably by having them wait 6 months before they start getting any points. So this is just basically a graph of this. You can see that if you don't have a living donor, there it is. If you don't have a living donor transplant, your MELD score grade is over 15. This is your probability of dying. If you have a living donor transplant, you can see you have a significant lower risk of dying as compared to those patients who don't have a living donor. So really the recipient benefit depends on the MELD score and the DSA, or the local area that results in transplantation. The benefits for HCC patients are diminished secondary to allocation preference for patients with HCC, and the benefits really depend on the availability of deceased donor organs. So let's talk about donor risk, because obviously you don't do living donor transplants without putting a donor at risk. It's estimated that the risk of death for living donors is somewhere between 1 in 100 and 1 in 1,000. Probably around 1 in 500 is sort of what's becoming an accepted number. But there is a significant risk of morbidity, somewhere in the 40 to 50% range, with, most of these are easily resolvable and don't result in long-term problems. Wound and urine infections, bile leak, pleural effusion, hernia, and other complications are the ones that were collected in the A2AL study group. And I enclosed that paper in your file. So one of the things we think about in living donor transplantation is what is equipoise. And equipoise is sort of an equilibrium of risk between the donor and recipient. So, for example, a patient enters a clinical trial. They're putting themselves at risk. And when we think about those clinical trials, we're thinking about the risk to the trial precipitant versus the benefit to society. And that's sort of one of the common thoughts about equipoise, is sort of putting that risk versus a societal benefit. And in living donor transplant, we're really trying to balance a recipient benefit and donor risk. So it's really what's been called by Mark Siegler, who's an ethicist at the University of Chicago, sort of what is really is double equipoise, because the donor takes risk to provide the recipient benefit, and the donor wants the recipient to have a successful outcome. And the donor wants to have a successful donation with sort of minimal risk as possible. The recipient has sort of a mirror image. He wants to minimize the donor risk. They want to have a successful donor outcome, but they also want to have a successful transplant, because obviously if the transplant isn't successful, then both the donor and the recipient have expended risks that otherwise they wouldn't benefit them. So one of the things that is sort of a given in living donor transplantation, we want to try and minimize the donor risk. And really what the donor risk is about is complexity of the donor operation and the amount of liver removed from the donor, so that as we remove more liver from the donor, the risks seem to increase. So that when we think about initially that first living donor transplants were done with a parent giving to a child, usually an infant, because most of the transplants in the pediatric population are done in those children less than 2 years of age, and really the biliary athletics make up most of those. And so giving the lateral segment, which is about 25% of the liver, it was the first risk that we provided to the donors in doing living donor transplants. And as you can imagine, most parents are willing to give up some, take some risk for their child. If you look at the left lobe, it's really 33 to 40% of the liver, and the right lobe is about 66% of the liver. So here's your liver broken out into segments, and here's your lateral segment, your left lobe, and your right lobe. So you can see that, as you move from farthest left to right, on your dial, you're really sort of increasing the amount of liver, and also actually turns out you're increasing the complexity of the operation. So in terms of looking at the donor risk, does it depend on which lobes donated? And this was the Vancouver Forum in 2006 collected a lot of the information about what the potential mortality risk is. And you can see that the left lobe, donating the left lobe was thought to have about a lower risk, about a 5-fold lower risk for donating the left lobe versus donating the right lobe. And there's Liz Pomfret at the Leahy Clinic. Somebody asked me who's the other transplant center that has a waiting list mortality that's as low as ours, and it's actually the Leahy Clinic. But she did a survey sort of around the world looking at what was the risk of death related to living donor transplant. And it's estimated there's about 14,000 living donor transplants that have been done, and there's been 34 deaths that could be identified. It's hard because a lot of these deaths are probably not reported. In India, there's a wide expansion of living donor transplantation, and there's been some concern that some of these deaths are not being reported. In what Liz found, there were 30 right lobe deaths and 4 left lobe deaths. And in the left lobe deaths, there were really 4 of those deaths that were one of them was related to a suicide, which obviously could be related to donation. In the United States registry, there were 5 total deaths, and 4 of those deaths were right lobes, suggesting that there's a greater risk of death in right lobes versus left lobes. In terms of the donors needing their own liver transplantation, there's been sporadic reports of donors needing their own transplants, and it's estimated that risk is probably 1 in 2,000. There's been no reports of a donor who's donated the left lobe of needing their own transplant. Usually it's sort of immediate need related to complications of the operation. So in terms of the donor morbidity, looking at the lateral segment, the left lobe and the right lobe, this is a sort of a collection of the literature, looking at a number of studies that looked at sort of the relative risks of donating these different portions. And you can see that morbidity of about 7% for donating the lateral segment, 13 for donating the left lobe, and 29 for donating the right lobe. And you can see that the right lobe donations tend to run in a range, and it probably depends on how people define risk. Looking at the relative risk, this was 2 studies that sort of, all other things being equal, and felt that the risk of left lobe as compared to right lobe was a 12th or a 4th as risky as donating the right lobe. So there's a real probably benefit to the donor to consideration of donating the left lobe versus the right lobe, and I think these were the studies that I'd show you that left lateral segment's the safest. The complications of left lobe grafts are probably somewhere in about 50% of right lobe grafts, and we think the risk is probably proportional to the size of the liver remnant in the donor. And so if the outcomes were the same in the recipient, we'd always use left lobes versus right lobes because the left lobes would be safer for the donor. The problem is that they're probably not the same. There's a lot of controversy over this, but really what is the difference is that when you put in a piece of liver that's too small, first off, when we put in a piece of liver into a recipient, we expect that liver to be able to grow, and over time, and really fast, within weeks, that liver will grow to probably 80% of its final size. If it doesn't grow, that recipient will probably end up going on dying, and that one of the things that prevents it from growing is if there's too much portal flow through the liver develops what's called small for size syndrome. That overwhelming portal blood flow probably injures the liver. So what happens after a partial liver transplant is that the liver gets the graft, the graft gets the flow that was destined for the whole liver, and we know that cirrhotics have a supernormal portal flow, primarily related to the splenomegaly and the increased splenic flow, because we know also that in people without portal hypertension, we can take out about 75% of the liver. That remaining lateral segment is enough to regenerate and allow them to, in the long run, to have normal liver function. We know that in living donor transplant that 40% is sort of our number, where if it's below 40% of the expected liver volume, that at that point the portal hypertension probably damages that liver and prevents it from regenerating normally. So really what you're asking for this piece of a liver to do is to regenerate and meet its metabolic demands of the body at the same time, and this hyperperfusion syndrome prevents that. They get ascites, coagulopathy, hyperbilirubinemia that go on to encephalopathy, renal failure, and death. Usually it starts in sort of the first postoperative week, and it's really a failure of the graft to regenerate. So these issues with the regeneration really have to do with the graft size, the regenerative response of the donor. So the younger donor obviously has the ability to regenerate much faster than a donor of older age, say 50. It also has to do with sort of the amount of portal inflow, and so one of the things that we think about is that we can decrease these portal inflow by doing various modifications of the portal inflow to the graft. And your portal hypertension is probably related to your child's class, your age, your size to your spleen, and you're probably reflected in your pre-transplant comorbidity. So one of the things to think about is that what's the relative benefit of a left lobe versus a right lobe graft to the recipient, and what role does the graft play in the outcome? And so one of the things in looking at small for size grafts is that there's been a number of studies that have looked at it, and there's controversy, at least for grafts that are close to 40% of the expected liver weight of the recipient, that there may not be a huge difference in outcome. But overall, everybody is of the sense that you can get to a point that's too small, and at that point there's injury to the graft. And one of the strategies has been to try and divert blood flow from the small graft by using portacaval shunts to shunt blood away from the graft, and then when after the graft's had a time to regenerate, the graft can accept more and more of the blood flow, and these shunts generally provide much less flow away from the graft. So one of the things that is unclear in the world of living donor transplant is this portal inflow modification for donors that give a small piece of liver and recipients who have large amounts of portal inflow. And so we have several different ways that we modify the inflow. One is to just ligate the splenic artery, and that decreases the blood flow to the spleen, well tolerated into the recipient, but just gives that ligating the splenic artery just decreases splenic blood flow long enough in order to allow the graft to regenerate. In Japan, where they do a lot more living donor transplants than we do, in patients with hepatitis C, they tend to do splenectomy. Their reasoning is that it's easier to treat the patients with hepatitis C afterwards if they've taken out their spleens, because they don't have as much trouble with cytopenias during their treatment with interferon and ribavirin, and finally a portacaval shunt, as we talked about. So one of the issues that we do is we look at portal pressure. We try to make sure that the portal pressure in the recipient isn't too high after we implant the graft, and we manipulate that portal pressure by a combination of those different things. We think that probably a portal pressure gradient of less than 12 to 15, so that the people really don't have portal hypertension after implantation of the graft. Those are the patients that probably don't need manipulation of their portal venous inflow, and so those are the ones that we think we can leave alone. And what we do is measure portal pressure during the operation, and then modify that if there's evidence of portal hypertension. So really, this is the left lobe graft that we put in the portal vein, and after we anastomose, say, the left portal vein, if the pressure's too high and we can't reduce that by ligating their splenic artery, then we would do a portocaval shunt. And this is basically the surgical procedure where we just take the right portal vein and anastomose it to the vena cava. In a couple patients where we've had problems late with the graft, the shunt taking too much flow away from the graft, the interventional radiologist can actually block off that shunt by using an Amplatzer. So I just want to show you a little bit about our adult-to-adult liver transplant experience. We've done 156 in adults and somewhat less in children, but over 100. We started emphasizing using the left lobe in 2006. So this has sort of been our experience by year, and you can see in 2006 is really when we started trying to do more left lobes if possible. Well, we have just tried to minimize the right lobes as much as possible, but not everybody can. Sometimes it's just going to be too small. So we've done, since 2006, we've done 39 left lobes and 19 right lobes, and these are our survivals. As Francis showed you, we have a very good outcome in terms of patient and graft survival. If you look at it, there's a few more grafts that are lost with the left lobes, and the right lobes didn't reach statistical significance. But it's, I think that in the end, there probably is some increased risk of graft loss in terms of left lobe, but we're really trying to decrease that donor risk and really transferring some of that risk from the donor to the recipient. You can see a little bit of this in terms of if we just look at the length of stay for the donor for the right lobe versus the left lobe, the left lobe has a significantly shorter length of stay for the donor. And I think, and if you look at sort of the course of these people, when we observe them, they tend to be out of bed more, they return to eating more quickly, and really have sort of a more rapid recovery in terms of hospital complications. Most of our complications are related to ileus from narcotics, but you can see that the complications, even in the people that donate their left lobe, it looks to be less. In terms of the recipient, we talked about, we do shift some risk to the recipients. If you look at the length of stay of the recipients, the left lobe recipients have a longer length of stay. They have a slower recovery, without a doubt, as compared to the right lobe. And these are the modifications that we've made in terms of the inflow with ligating the splenic artery or doing portosystemic shunts in these patients. So really, a living donor transplant is sort of a balance between this donor risk and recipient benefit, and I think I feel strongly that if the left lobe was safer for the donor, and even if it is more hazardous to the recipient, we're doing an operation, the donor, that they don't need to have, and we try to emphasize doing left lobes in the donors, and it's really well accepted by the recipients. I think the recipients are always uneasy about the risk that donors are putting themselves to, and when we talk to the recipients and we say, we think this would be best for the donor, there's less risk, you have more risk, and they say, I'll take that risk to decrease the risk in the recipient. And so I think it's really important that everybody, including the donors, recognize that, and the recipients recognize that there is this decreased risk, and the recipients are willing to take that increased risk to themselves. I'm late for time. I just wanted to talk about, I'm going to skip this one. It was just an example of a patient, but I'm out of time because I talk too much. So in terms of the risk of death for left lobe transplantation, it's probably 5-fold less than the right. The risk of complications are probably 4 to 12-fold higher after donation of the right versus the left, and the complications may be more severe. The role of graft size to outcome is unclear for graft weight to recipient standard liver volume, so graft weight to standard liver volume, we can calculate sort of what we would expect the liver volume to be in the recipient of probably 30%. And some of these donor-recipient combinations were in the 25 to 30% range. So, we're putting a fair amount of risk to the recipient, and the inflow modification may be important in improving graft outcome, and we just have to try and decide sort of what is that balance of portal inflow versus graft regeneration. I think age of the donor is probably one of the more important factors in this, because a young donor liver can actually regenerate in the face of a fair amount of adversity. So really, we're looking at shifting this risk from the donor to the recipient, less donor morbidity. There's no clear increased recipient mortality or graft survival risk, but I do think, just based on our length of stay data, that we have increased recipient risk with using left lobes or other smaller grafts. I'd like to thank Hillary Braun. She was one of the medical students that dug in and reviewed our most recent data. Nancy Asher, Chris Fries, and then the whole UCSF team who you got to meet here today are really the reason why we can do all this stuff. But thank you very much.
Thanks, John. That's really important and cutting-edge stuff. We can take one or two questions. Maybe I'll ask the first one. So I just got a question. So you have a patient with a low MELD score of 10 who's got bad ascites, requiring large volume paracentesis. So the debate is whether to subject somebody with a low MELD score with complications. Is it ethical to do live donor transplant?
Well, again, it's really looking at the risk of recipient benefit to donor risk. And so, some of the people that have very low MELD scores, some of their benefit for transplantation that they gain is quality of life. And, obviously somebody that has difficult to treat encephalopathy or ascites, their risk of death may not be that high. It turned out when we looked at the data showing you those low MELD scores, if you have a low albumin, your risk of death is much higher, and probably the same with low sodium. So I do think in the A2ALL study, where they looked at sort of, is there a minimum of the risk of death? Around 10 is probably a MELD score of 10. You're down to sort of an area where the risk of undergoing living donor transplant is still valuable. We think that for cadaveric transplant or deceased donor transplant, that number is probably about a MELD score around 15, that below 15. But for living donor transplant, because you actually have this less risk of death while waiting on the list, that I would consider that patient for living donor transplant.
Great. Okay. Thank you very much. Oh yes, Dr. Osaka.
So the question is that in the people that have had the portosystemic shunts, what's the rate of portal encephalopathy? We've only had to take down 2 shunts because of portosystemic encephalopathy. Both of them actually showed up relatively late, about a year after transplant, and both of them were manifest by the usual of high ammonia and fatigue and actually asterixis. As I talked about, the radiologist can go down. We don't have to reoperate. The radiologist can go down and occlude the shunt. So we think that it's probably reasonable. I think one of the things that there's a lot of discussion in the transplant world about, one is I think we were trying to avoid the shunts more by trying to predict who actually is going to need them based on the pressure gradients. And there's also sort of people are thinking about, how can we create these shunts and then take them down just on everybody at, say, a month, because that's all the time. You only need them for that early post-transplant time period. Thank you for the question.
Okay, great. Thank you.